Is that right? Okay. Assalamualaikum and very good morning to all the participants. First of all, I would like to thank all of you for registering and participating in this first National Emergency Critical Care Update course for paramedic for the year 2021. With that, I would like also to thank the organizer committee from College Sains Kesihatan Bersekutu, BPL, Ipoh Emergency Critical Care Society, and the alumni of Malaysian Paramedic Emergency Critical Care. So I am very much grateful and glad that this course was able to be held despite of training and limitation that we have during our COVID-19 time. And I hope this course going to be the pioneer course for the National Emergency Critical Care Update for the paramedic. And this course was initially planned for the for face-to-face course with hands-ons, but due to the limitation of COVID-19, we start off with these initial webinars. Hopefully, in the future, we will be able to do bigger face-to-face and more hands-on station for all of you. This course basically just to keep the ball rolling. So I hope you guys enjoy and get benefit from this course. I don't want to talk much about the course. So enjoy the lectures, have fun, get as much as information that you want. You can ask question at the end of each presentation if you have enough time. And I would like to thank you again to the organizers, to the speakers, to the presidents of alumni of Emergency Critical Care Paramedic Malaysia, and also to Puan Syamatul from the College Sains Kesihatan Bersekutu Ulu Kinta, Sultan Azlan Shah Ulu Kinta, and again enjoy the course. Thank you again and happy learning. Assalamualaikum warahmatullahi.
Okay. Alright. Assalamualaikum. Hello and welcome to today's webinar, Updates in Emergency Critical Care Course for Paramedics. Today, our webinar is all about uncovering updates on emergency critical care for all paramedics. Before we get started, I'm going to go through some housekeeping to ensure you can interact with myself and the speakers. Firstly, we will have our Q&A session towards each end of each session. If you wish to ask the panelists a question, please click on the yellow raise hand icon on the bottom right of the screen. Or we also have a Q&A features enabled. To access this, simply click on the Q&A icon or button there. And if you experience any issue regarding hearing today's webinar, please do contact our crew. The support team will help you troubleshoot any issues. Ladies and gentlemen, please be aware that all e-certificate will be emailed to everyone a week after our 2 days webinar. I repeat, the e-certificate will be emailed to everyone a week after our 2 days webinar. Please be expected in delay of the live streaming due to the strength of our telco or internet carrier. Before we start the webinar, and in order to avoid any disturbance during the presentation later, I would like to ask you to change the mode of your gadget into silent mode. I repeat, to avoid any disturbance during the presentation, I would like to ask you to change the mode of your gadget into silent mode. The Honorable Mr. and Madam Speakers, distinguished guests, fellow alumni, students, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. First, I would like to welcome you all to this prestigious webinar regarding updates in emergency critical care course for paramedics. This webinar series, held by the Malaysia Paramedic Emergency Critical Care Alumni and co-organizer with Ipoh Emergency Critical Care Society and Institut Latihan Kementerian Kesihatan Malaysia (IECCS) Sultan Azlan Shah. And most importantly, our sponsored SMS MPECCA at Sendirian Berhad. Thank you for the support. In this occasion, the organizer had prepared an outstanding presentation from our prominent panelists, whom I believe shall enrich our insight and knowledge regarding the theme of our today webinar. My name is Amirul Shahrudin. I'm a pengajar from Training Management Division, Ministry of Health, based in Putrajaya, and I'll be your moderator for today and tomorrow. Ladies and gentlemen, the objective of today's webinar, Updates in Emergency Critical Care Course for Paramedic, is expected to fulfill the following objective: to provide the latest evidence-based emergency critical care updates in practice, to inspire the seamless transition of patient care from the emergency department to the inpatient ICUs by enhancing the capacity and capability to deliver high-quality emergency critical care, to produce competent leaders and trainers among paramedics in emergency critical care. I would like to take all of you for a brief for today's agenda. As we can see here from the screen, we will be together until around 12 afternoon. The sharing session for today, we have 5 panelists with different topics. So we do hope everyone is ready with pen and paper and find a comfortable spot for the best and the rest of our webinar today. And first of all, thank you again, Dr. Azma, for the opening remarks. Before we start the session, allow me to share some introduction for our first panel. We will start with the first panel of the day, Dr. Yong Chee Kheong. He was graduated from Manipal Academy of Higher Education and continue for specialization in emergency medicine at University of Malaya. He is an emergency physician for head of department from Hospital Raja Permaisuri Bainon Ipoh, a fellow in emergency critical care and active in research and publication. With the title Resuscitation and Update, I present to you Dr. Yong Chee Kheong.
Good morning to Mr. Miro. Thank you for your kind introduction. Welcome everybody to the updates in emergency critical care course for paramedics. First and foremost, I would like to thank the organizers for organizing this course, especially for the paramedics in Malaysia. And I would like to thank all the paramedics out there for their services in this COVID-19 for the past 1 year. The life has been tough. I know you all have been working very hard, continue working hard. Together, we stay strong. We will fight COVID together, 19 together. All right. So all shout out to all the paramedics out there for all your hard work. All right. So today I will start my presentation on resuscitation and update. So which is a very important part of emergency medicine, assessment, resuscitation, and monitoring the patient of critically ill patient while the patient is in emergency department. And what are the updates of this topic? We will share together and we will talk together what is the latest we can learn. So there is no disclaimer. My outline of my topic today, we will discuss mainly on three very important topics in resuscitation. There is a review of physiology of blood flow and heart-lung-brain interaction during CPR, recent advancement in cardiac arrest research, hemodynamic monitoring in critically ill, and I will put a slide at the end of the presentation regarding the American Heart Association 2020 guideline of post-resuscitation care, right? So what's the principle of CPR? So basically, when the cause of the arrest is unavailable, the primary treatment is very important to fully restore cardiac and brain function. The first critical step is to restore mainly the blood flow to the vital organs, that is our brain and our heart, right? So this is the principle of CPR.
Dah besar ada. Yang kecil tak ada? Tak ada. 7E je lah bang.
So for early and effective CPR is one of the ring in the chain of survival. During CPR, external chest compression is performed to generate blood flow from the heart to the systemic circulation. This technique was first described by Hoven, and it remains the same technique for the past 50 to 60 years. So there are two classical theories to explain the mechanism of blood flow during CPR, namely the cardiac pump and also the thoracic pump. And we will go through these two theories together. So firstly, what is the cardiac pump theory? Now, the heart valve functions to ensure one-way blood flow, and the coronary arteries are actually perfused during decompression. External chest compression squeezes the heart between the sternum and the vertebral column and forcing blood to be ejected out from the heart. And heart coronary perfusion or heart preload refills occurs during relaxation or during the recoil of the compression. And coronary arteries are actually perfused during a normal functioning circulation with normal valves. So that's the cardiac pump theory. And the second theory of CPR is the thoracic pump theory. The thoracic pump theory postulates that chest compression increases the intrathoracic pressure. So in this theory states that the heart is functioning as a passive conduit rather as a pump, and all the heart valves remain open. So during chest compression, it increases the intrathoracic pressure and intrathoracic arterial vasculature pressure. This pressure gradient causes blood flow to extrathoracic vessels. And during relaxation or during chest recoil, there is a fall in the intrathoracic pressure, causes venous return to the thorax, and the arterial blood return into the coronary arteries. So therefore, the heart is acting as a passive conduit rather than a pump, right? So both the cardiac pump and the thoracic pump involve chest compression to generate a forward flow, and there is controversy regarding which one is the predominant mechanism. From the literature, we found that there are studies that supported each of these theories, but more recently, researchers have found that cardiac pump or thoracic pump theory alone cannot explain the mechanism of the blood flow, and other theories were introduced. So we all know that high quality CPR includes the depth, the rate, the minimal interruption, full chest recall, and avoid hyperventilation. So from the understanding of this mechanism of blood flow, we all know that full chest recall is important. Why? In practical, chest recall is probably the most underrated and underappreciated, underachievable component of CPR. Right? We never pay much attention on what the importance of full chest recoil. So how this has been translated into the latest technology that help us during CPR. Certain newer generation of defibrillator machines will actually give you a real-time audio-visual feedback on the screen of the defibrillator. It will translate and give you the depth, the rate, the chest recoil, and also the perfusion of the patient during CPR. And this has tremendously helped us and guide us to do a very high quality CPR for the patient. So although there are different hypotheses for the forward flow mechanism, however, most of the studies prove that the refilling of the heart depends on the decrease in the intrathoracic pressure. So thoracic pump plays a very important role of blood flow during chest compression, as in this study published in Resuscitation by Marius Giorgio et al., systemic review of the mechanism during effective blood flow during adult CPR. And they found that most of the mechanism of blood flow are actually due to a decrease in the thoracic pressure. So therefore, it brings us to the question of full chest recoil. How full chest recoil is important during CPR. So a return of the blood to the heart is a form of a preload, right? When your preload increases, it increases your coronary blood flow during a diastolic filling. And negative intrathoracic pressure helps returns blood to the heart. It increases arterial blood flow, and it decreases your ICP and increases your cerebral blood flow. So how are we, based on the standards understanding of now the heart-lung interaction, there are certain devices that are designed to improve blood flow during CPR. And these are just the adjuncts designed to enhance the effectiveness, not to take over, but to enhance the effectiveness of CPR based on different theories. For the thoracic pump, there are mechanical devices like the thoracic pump, respiratory pump, and cardiac pump adjuncts. So if you look at thoracic pump, you have a load distributing band CPR device, or what we call an active compression decompression device. For respiratory pump, we have a device called the impedance threshold device. And for cardiac pump, we have a mechanical piston CPR device. And we will go through each of the device after this. Okay, so first, let us talk about impedance threshold device. What is an ITD? So this device is actually placed between the airway and the back valve mask, and it can be used on the face mask or on an ETT. So it is a valve to prevent actually passive air entry during chest recoil, but it allows airflow during positive ventilation. So it actually, when we give the breath, it will deliver what we want to give. But during chest recoil, when it creates a negative pressure, it prevents air sucking in, right, into the lungs. So the reason of chest recoil and ITD is actually it creates a more negative intrathoracic pressure. So how it helps? When the chest recoil and the ITD is used in combination, the negative intrathoracic pressure will actually be generated, and it will increase and draws more blood returning to the heart, right? So when you have a increase in the venous return, there will be definitely increase in your cardiac output, improve in the cardiac output. So what are the studies? What is the evidence that we have about using impedance threshold device in out of hospital cardiac arrest? So we look at this journal published in the New England Journal of Medicine, a trial of an impedance threshold device in out of OCA. So this study was actually done in 2011 across in US and Canada. They recruited 8,718 participants. So it studied on the use of impedance device as an adjunct to conventional CPR. However, the study showed there was no improvement associated with the use of ITD compared to another device or conventional CPR as an adjunct, all right? There's no improvement in the patient. So in 2015, what AHA did was, AHA has dropped the recommendation on the use of ITD from class 2A to class 3 evidence. So basically, initially they was talking about benefit more than risk, but AHA has changed their guideline in 2015 to class 3, that is benefit is equal to risk. There's no added benefit to it. So therefore, the routine use of ITD as an adjunct to conventional CPR was not recommended. However, if you read the study properly, there was a major limitation on this study. So there was a great variation of BLS protocol that was observed across the study sites. There were more than actually 50% of the patients received a substandard CPR, all right? They received substandard CPR compression. So they did another subgroup analysis on the patient who received good CPR. Okay, so they did, from the study, they did a subgroup analysis on those patients that they really did a high quality CPR. And what they found out was, in patients that with a good CPR performed, the use of ITD actually increases the survival with good neurological outcome. Therefore, conclusion of the study was a good CPR is fundamental, and the use of ITD improved the outcome in cardiac arrest, based on the study published in Resuscitation in 2015. Okay, so let's move on to mechanical CPR devices. So the first one we quite commonly we use are usually the load distributing band devices, and the advantage of it is it gives a circumferential compression. It is designed based on thoracic pump theory, and the band is actually wrapped around the chest and make a circumferential compression. So this device, load distributing band device, is actually designed based on a thoracic pump theory. And then you have the other another type, that is the piston type mechanical piston devices, which is based on pump theory, cardiac pump. And the piston is actually compressing on the sternum to give a direct compression to the heart. Besides that, it also adds on an active chest compression. All right, there is a suction cup that sucks the chest up during decompression to create negative pressure, intrathoracic pressure. So this is actually both a cardiac compression, and also it sucks up, improve the chest recoil to create a negative intrathoracic pressure. Why negative intrathoracic pressure is important? The more negative it is, the more venous return it is. Okay. So what are the key theoretical benefits of mechanical CPR compared to giving a high quality chest compression? Now, what we believe the theories of the benefit are basically to reduce the rescue fatigue, to ensure appropriate depth and rate, and also to minimize interruption during transports and procedure. So we can see very obviously from this graph is the moment chest compression is stopped or halt, the perfusion drops very fast. All right, the perfusion drops very fast. For that 10 seconds that we will need to assess the patient, the perfusion actually drops. And when the chest compression resumes, it actually takes time for the perfusion to pick up, right? So we try to minimize interruption as much as possible during CPR. But much of the studies, even though initially was very encouraging, most of the studies was actually done in devices for out of hospital cardiac arrest. And what they actually found out in this paper published in Resuscitation, Mechanical Chest Compression for OCA, Systemic Review and Meta-Analysis. They are comparing the use of mechanical CPR with the primary outcome, looking at ROSC and also survival with good neurological outcome. What they actually found out was it did not improve, mechanical CPR did not improve the neurological outcome and cardiac arrest compared to a manual high quality CPR. Since the current evidence does not show any clinical benefit with the use of mechanical CPR over manual high quality chest compression. Therefore, manual high quality chest compression still remains the standard of care. But the guidelines recommended it as in the ILCOR 2015 AHA guideline, recommended as a reasonable alternative. And in practical, we encounter situation where it's difficult to do a hands-on manual high-quality chest compression, especially during transport or during when we are lack of rescuers to perform a consistently good CPR, right? Most of the studies of mechanical CPR are done in out of hospital cardiac arrest. There are only few studies that comparing medical CPR in hospital, especially in emergency department. However, there was one study was actually published by Marcus Ong from Singapore, using mechanical CPR device in ED. So, right, it published in Critical Care 2012, improved neurologically intact survival with the use of automated load distributing band chest compression device for cardiac arrest presenting to the emergency department. And what they found out was this study showed that the use of mechanical CPR improved the rate of ROSC and also survival. So then the group people are thinking, what about us combining the use of impedance threshold device plus a mechanical CPR? Right? Recent studies reported significant improvement in both survival and also neurological outcome over standard CPR using a combination of mechanical CPR with an impedance threshold device. Therefore, they actually works better if combined the use of it during resuscitation. And it was actually echoed in the 2015 AHA and also European Resuscitation Council guideline that it advises a single use or ITD alone is not recommended, but the combination of ITD plus a automated compression device may be a reasonable alternative, right, to conventional CPR. So a very interesting study that was did by Debati et al. Using a trial of heat-up CPR using a animal study. So traditionally, we do CPR on the patient on the supine position. So this study, animal study, looking at coronary and cerebral perfusion pressure on a different position of the patient during CPR, right? So one group of patient is up, one group of patient supine position, and one group of patient heads down. So what this study found that when we put the patient or when they put the animal study on a head up position, it actually increases the coronary perfusion pressure and also cerebral perfusion pressure, right? So it improved the brain flow in the profile model of the cardiac arrest based on research published in Resuscitation back in 2015. All right. So the graph shows that when the CPR was done in a head up position, it actually reduces the ICP and also increases the cerebral perfusion pressure. However, so far, this is only done on an animal study, has not yet to be conducted on a human study. So it is important to understand the physiology and CPR, then only we can recognize an effort in improving cardiac arrest care, right? CPR adjuncts can help to optimize the quality of the CPR and improve the outcome. So emphasis still gold standard should be high quality CPR, okay? So that will be the CPR updates. Next, we will talk a bit about hemodynamic monitoring of critically ill patient in emergency department. Okay, So at bedside, hemodynamic stability and tissue perfusion are actually monitored by a combination of, never forget, gold standard clinical examination, monitoring device, and also laboratory results. And the data obtained are used to direct a clinical course of management for the patient. Remember, the focus is actually to our patient, management of our patient, and not technology centered. Therefore, in practice, the monitoring devices are employed in a series of increasingly invasive and complex steps based on clinical examination and the patient response to the treatment itself. Now, how are we going to assess the patient? You have non-invasive and invasive monitoring, but generally today I will be talking more on non-invasive assessment and monitoring of the patient's global and regional perfusion, right? So what are the initial steps? First, clinical assessment of the patient. Number two, basic monitoring of assessment of global perfusion. And number three, preload monitoring and also fluid responsiveness. Of course, we have the more advanced monitoring measures like the cardiac output, assessment of cardiac contractility, and also assessment of tissue perfusion. So step one, clinical assessment. So first, assess the patient. Is the patient actually thirsty? Assess the extremity, whether is it cold and clammy. Look for the pulses. How's the volume? What's the rate? And look for CRT. All right, and these are all immediate and useful indices to indicate whether the patient is in shock or not in shock. So when the patient is having inadequate global perfusion, patient will actually develop tachypnea, tachycardia, confusion, altered skin perfusion, and also reduce in urine output. So in early stages of shock, patient's skin may be flushed, warm, and vasodilated when the patient is compensatory mechanism. When the patient is decompensated during the later stage of shock, patient develops cold and clammy peripheries and become hypoperfused. And peripheral circulation is the first to reflect a disturbance of the circulation that may lead to shock. Therefore, clinical assessment of the patient is very important when you first engage with the patient. Assess the patient peripheries, patient's respiratory rate, heart rate, and um, peripheral extremities. Okay. So there's something called a mottling score in this patient where we assess the patient at the knee to the groin area. So this mottling score, if there is no mottling, score is 0. When the mottling score is 1, there's a small area of mottling localized at the center of the knee. Your score 2, when the score is 2, modest mottling area that does not extend beyond the superior border of the kneecap, all right, as illustrated at the picture. And score 3, mild mottling area that does not extend beyond the mid-thigh. Score 4, severe mottling area not going beyond the groin. And score 5, there's a severe mottling area extending beyond the groin fold. Therefore, what it tells you is the more mottling the patient has, the more hyperperfused the patient is. Okay, so this can give you a rough guide how the patient global perfusion is. And next is we assess capillary refill time. All right, for most young children and young adults, CRT should be less than 2 seconds. And anything that is higher, substantially higher in healthy women, more than 2.9 seconds, and elderly more than 4, it is considered prolonged. Okay, CRT assessment is especially important to pediatric patients because it is a good predictor of dehydration, and it shows that the child has a reduced in stroke volume and increased blood lactate levels. Okay, and then assess the skin temperature of the patient, best estimated using the dorsal surface of the hands and the fingers. And patients are considered to have a cool extremity. If all examined extremity are considered cool by the examiner, or if only the lower extremities are cool despite warm extremities in the absence of peripheral vascular occlusive disease. Now, step 2 is to assess the basic monitoring and assessment of global perfusion. All critically ill patients are advised to have ECG done, arterial blood gases, and pulse oximetry monitoring. Baseline measurements and biochemical variables should be measured for patients with global perfusion. Now, pulse oximetry is actually based on two physical principles. The first is actually the presence of a pulsatile signal generated by arterial blood, which is relatively independent of non-pulsatile arterial blood, venous and capillary blood, right? So it measures the arterial blood pulsation. Number 2, the oxyhemoglobin and reduced oxyhemoglobin have actually different absorption spectra. Why? It actually measures the changes in the light absorption of oxygenated and deoxygenated blood. So there is two wavelengths in the pulse oximetry. One is a 660 nanometer, and one is a infrared. So therefore, it uses infrared to measure the oxygenated and deoxygenated blood in pulse oximetry. So look at certain waveform that we commonly see in the monitor, pulse oximeter. So the first one we can see usually is very good perfusion. It gives you a very normal sign. Though the second waveform is a bit flattening, patient may be having a very low perfusion. And if the patient is having motion artifacts, the patient is moving, you can see that kind of waveform commonly, all right, during the last, in the lowermost waveform, there's usually the motion artifact. So what are the limitations of pulse oximetry? All right, it actually cannot measure carboxyhemoglobin and methemoglobin. Pulse oximetry is very difficult to measure, especially patient in low perfusion state, patient with anemia, and also patient with a thick nail polish. Okay. So how pulse oximetry give us some ideas of the early warning of hypoxemia, and pulse oximetry can also give us a guide to titrate the FiO2 in patient requiring mechanical ventilation, because pulse oximetry is a non-invasive, so we don't have to assess every time the patient using a arterial blood gas. So how SpO2 monitoring is important, and also knowing the limitation of SpO2, right? So SpO2 signal is often inaccurate in the presence of altered skin perfusion. And also usually it is difficult to obtain a very accurate oxygen saturation, especially in carbon monoxide poisoning. Okay. So in our critically ill patient, we suggest that SpO2 should be maintained at least more than 92% in all or most of our critically ill patients. So this brings us to the next question of serum lactate. All right, very commonly we discuss about serum lactate as a marker of tissue hypoperfusion. So a normal serum lactate level is usually less than 2, but an elevated, therefore an elevated serum lactate level will actually represent poor tissue perfusion, right? The association of increased lactate levels is actually associated with circulatory failure, anaerobic metabolism, and also the presence of tissue hypoxia. And the use of this lactate actually led us to use it as a monitor to tissue perfusion in critically ill patient. Repeatedly, measurements of lactate concentrations over time are particularly useful for monitoring the response to our therapy. So the step 3 is assessment of preload and fluid responsiveness, right? So how are we going to do that? Assessing fluid responsiveness, a simple maneuver we can do bedside in emergency department is by doing the passive leg raising test maneuver. So first the patient is put in a semi-recumbent position, and then after that, patient supine with legs were elevated to a 45 degrees, and we are pushing actually the blood from the periphery and the abdominal compartment back to the heart. So in the presence of hypotension, it is important step to assess preload and fluid responsiveness, right? Preload can be defined as the volume present at the end of the diastole before contraction of the ventricle has started. And fluid responsiveness is frequently defined as an increase in the cardiac output 15% from the baseline with a mini fluid challenge. It's either you can give a small mini fluid challenge or you can do the passive leg raising test. We can actually start the patient, give a patient of a small fluid challenge around 250 cc of crystalloid, 10 to 15 minutes, and observe the effect of blood pressure and jugular venous and central venous pressure, and also the patient's stroke volume, whether the patient is actually fluid responsive or not. If the patient is not fluid responsive, there is no increment in cardiac output, then there is no necessity to give extra fluids because the risk of overload is high. Therefore, there may be need of start the patient on early inotropic or vasopressic support. So take-home message for hemodynamic monitoring is an important part of patient assessment in emergency department. Regular monitoring of critically ill patient is vital in resuscitation, and multiple techniques of monitoring provide valuable additional information during the course of the patient in emergency department. Last but not least, just to share the latest AHA update 2020 regarding post-resuscitation care. I would just want to stress a few important points during post-resuscitation care. That is the use of capnography has been emphasized, right, in the latest guideline to confirm and monitor endotracheal placement. And we should avoid hypoxia. We should avoid hyperoxia. We should actually keep the SpO2 between 92 to 98. And also, if the patient hemodynamically unstable post-resuscitation, either we administer a crystalloid or early vasopressor or inotropic support to maintain a mean arterial pressure of more than 65 millimeter mercury. Right, that is very important. Number 2, continued management of additional emergent activities like targeted temperature management. All right, this is following post-resuscitation care. We should start TTM as soon as possible, cooling the patient at 32 to 36 degrees Celsius for 24 hours by using a cooling device with feedback loop, right? And also we should try to obtain the patient 12-lead ECG. If the patient needs a cath lab activation showing ECG showing STEMI, then we should get the patient going to the cath lab as soon as possible for emergency PCI. And other critical care management is to make sure continuous core temperature, maintain normal oxia, normal capnia, and also euglycemia. And I think another main thing that here is to make sure the patient is provided with continuous or intermittent electroencephalography EEG monitoring for post-seizure prophylaxis. And last and foremost is provided a lung protective ventilation. Okay, so that is the end of my presentation today. Thank you again to the organizers. I hope you all learned something from the resuscitation update. There are many more speakers waiting to give their talk. So thank you very much to the organizers.
Thank you, Dr. Yong, for amazing sharing. So for those who have questions, Dr. Yong will reply it personally at the Q&A session. Okay, at the Q&A box. So if you can see at the bottom of your the screen, they have a Q&A icon. So there has some question which Dr. Yong will be personally answered